Our next paper is Aortic Luminal Contrast Attenuation Varies with Dissection Morphology and is associated with the need for intervention by Dr. Feldman and colleagues from the Fruit Street Clinic in Boston.
Thank you for the opportunity to present our work, and again, a shout out to our middle of the night drivers who got us here for this, and a full day of skiing as well. So we have no disclosures. So I'd like to set our focus within acute type B aortic dissection to those patients who don't immediately warrant intervention. As we're familiar with, many of these patients do go on to require intervention after their initial presentation, either from malperfusion, long-term aneurysmal degeneration, or rupture. Yet we have limited prognostic tools in our arsenal to separate out these patients a priori. Prior work from our group has demonstrated that the initial CT scan may hold some promise in this, and indeed found that intervention was predicted by maximum aortic diameter, maximum diameter of the false lumen, and entry tear size. So we hypothesized that we could add to this arsenal and interrogate the presence of fenestrations and relative contrast density between dissection lumina that may assist in prognostication. So we conducted a retrospective review of all adult patients with acute type B aortic dissection who presented with a dual phase CTA on admission from 1999 to 2020, whose dissection didn't span the site of a prior repair or a previous dissection. We then examined every single admission CTA for dissection morphology. We classified them according to the SVS STS guidelines. We characterized all fenestrations. We calculated centerline diameters and included standard demographic and other data. However, our primary exposure used contrast density, measured by Hansfield units across the septum, as a surrogate for what we hoped would be relative pressurization of the false and the true lumina. We constructed new parameters to characterize this, termed Hansfield unit ratios, or HURs. We parameterized these HURs in two ways. Our primary exposure took the false lumen contrast density and compared it to the true lumen all within the arterial phase to get a sense of arterial pressurization of the false lumen. Our secondary exposure took a different look. We looked at the false lumen alone, not the true lumen, and compared the venous phase to the arterial to get a sense of delayed filling of the false lumen. In that latter one, we normalized to the aortic root to account for differences in contrast timing between the phases, variations in cardiac output, etc. Our primary outcome was need for intervention, and we additionally looked at growth, false lumen thrombosis, mortality, and survival. Moving on to our results. We found 74 patients with the requisite CTAs on admission, with the majority being male, white, and over 50. The median diameter of the dissected aorta was 4.2 centimeters, with true and false lumina approximately equal in diameter. The dissection extended across a median of 7 zones, but varied widely. The entry tear was most commonly found in zone 3 and was of approximately 1 centimeter in size. Fenestrations were found in nearly 60% of patients. And were most common in zones 4, 5, and 9, but were observed throughout zones 3 to 10. Depicting this schematically, this maps out every patient in this acute cohort with the extent of dissection depicted in blue and fenestrations depicted in black circles. Zone 3 was most commonly the proximal extent. Zone 10 was most commonly the distal extent. And again, this shows the map of the fenestrations, and you can see that they're present throughout zones 3 to 10. Now on to our primary exposure, summarizing the HURs. Our median arterial phase false to true lumen ratio was 0.89, but as you can see with a wide range. Median venous to arterial false lumen ratio is 1.2, again with a pretty wide range. However, the presence of fenestrations, as expected, this is just a schematic of what those look like. The presence of fenestrations led to equilibration of these ratios, here demonstrating that with fenestrations, both ratios are closer to 1 as opposed to without, kind of validating that these are giving a sense of equalization of pressures here. Now moving on to our outcomes. Median follow-up was nearly 4 years, with a slight increase in aortic diameter when you take a median of all patients to 4.3 centimeters from 4.2, with growth observed in 27% of patients. The false lumen was thrombosed in only 5% of patients on follow-up. There were no 30-day mortalities and only 1 aortic-related death in follow-up. Intervention, however, occurred in nearly 70% of patients, with a median interval of approximately 2 weeks. Malperfusion was the most common indication. Now taking a deeper look at the interventions. Breaking these down by indication and modality. TVARs were the most common performed and performed approximately equally for malperfusion or ischemia, long-term aneurysmal degeneration or other, which includes refractory hypertension, refractory pain, or rupture. Renovisceral stents, you'll see, frequently accompanied TVARs for malperfusion. Open repairs were quite common, most often in delayed fashion for aneurysmal degeneration. Fenestrated and branch grafts were rare, as were infrarenal EVARs. Now looking at the time till intervention. This depicts in a box plot that intervention varies widely, or time to intervention varies widely, with malperfusion driving quicker intervention, typically within 2 weeks, which is not surprising, and aneurysmal degeneration driving intervention at approximately 2.2 years. Now taking another look at our HURs, our Hounsfield unit. This is the same numbers that I presented before. However, now we're breaking it down by intervention. And here we can see that the presence of intervention was associated with significantly greater arterial HUR and a significantly lower false lumen venous to arterial HUR. There were no associations between HURs and aortic growth or false lumen thrombosis. However, when we interrogate this with univariate regression, we find that an odds ratio of 25.3 was found for intervention in patients with a 1 point greater arterial phase HUR, with a commensurate converse relationship in the delay to arterial phase ratio. Moving on to the overall survival of this population, median long-term survival was 12 years. And using univariable Cox regression, we found that a similar dynamic occurred, where an increased arterial phase HUR led to, or was associated with, I should say, decreased long-term survival with a converse relationship in our false lumen HUR. So in summary, we found that among our acute type B aortic dissection patients, morphology varied quite widely, with fenestrations common in the thoracic aorta, a median dissection extent of approximately 7 zones, however, with significant variability there. And we found that our newly constructed HUR parameters for contrast attenuation between the dissection lumina may serve as surrogates for pressurization of the false lumen. Downstream intervention was quite common at nearly 70%. And most notably, a higher ratio of contrast density in the false lumen was associated with increased need for intervention with an odds ratio over 25, and a commensurate relationship in our delayed phase HUR. Overall, these calculated permutations of HUR may serve as a viable surrogate for arterial pressurization of the false lumen, delayed venous pressurization of the false lumen, in what is otherwise a static CTA, and may help us bridge the gap between static and dynamic analyses to correlate with downstream intervention and help us prognosticate. Of course, these conclusions should be interpreted in light of several limitations. Of course, this is a retrospective study from a quaternary center. There were no uniform protocols in existence to drive decision-making or to guide decision-making. There's, of course, a limited sample size of people who came with a dual-phase CTA. There may be some component of confounding by indication for that imaging study on admission. But this also leads to low event counts for certain outcomes like mortality, false lumen thrombosis. And accordingly, we're unable to adjust for covariates with multivariable adjusted analysis, just given the low event counts here. And we are, especially with earlier patients in our cohort, we are unable to correlate the CTA with timing of symptoms, only timing of admission. With that, I'll finish and open for questions.
A great presentation. It's 21 years of data and a lot of surgeons, I assume. So maybe you can comment on consistency of care pathways. If I'm reading the data correctly, there were no patients treated with prophylactic TVAR who were uncomplicated. And did I miss that? So it seems like there may be some surgeon-to-surgeon variability in, I believe, in prophylactic repair of uncomplicated type B aortic dissection, as the latest data is starting to suggest, or even interpretation of refractory pain and hypertension where it gets a little bit soft. And so, A, how much consistency is there, you think, in care pathways over such a long period of time, and how does that impact your data? And then B, what are you doing with it? Are you starting to change your practice pathways? If you're a group that wasn't doing uncomplicated type Bs prophylactically, have you started to do so in using this ratio to predict which patients may benefit?
Thank you for your questions. So yes, it's a long period of data. There's definitely inconsistency and evolution. More of our open repairs were done in the earlier period, although we still do quite a number for aneurysmal degeneration long term. In terms of uniform practice patterns, they certainly varied with surgeons. However, I would say that it's pretty consistent that prophylactic treatment of uncomplicated type B is not a consistent practice at the MGH, and especially in this time period ending in 2020. Now, you highlighted one of the difficulties with this. Even with chart review, it's difficult to ascertain the surgical decision-making. How much of a refractory pain was really driven by pain? Was it hypertension? Was there a change in exam that wasn't documented, et cetera? Was there a rise in creatinine that led to a concern for dynamic obstruction that was worsening for the renal arteries? That sort of thing, we don't have exact granularity to be able to suss that out, although I'm sure some combination of those are at play. In terms of how we're going to use this going forward, well, first of all, the data is retrospective. I don't think we can just say, hey, we have an answer, let's go ahead and change practice. What we're actually trying to do is work with our radiology colleagues to develop a prospective study where we're going to use time-resolved CTA, basically a CTA movie, to further assess this with a volumetric analysis of contrast density to help us potentially have something that we can use in the radiology suite to help us drive care in the acute period, not hyperacute, but acute, instead of having me go and measure CT scans for hours and hours on end.
Thank you. I also enjoyed your presentation, and I completely agree that the initial CTA, you can extrapolate a lot more than the morphologic data that's present to determine sort of the natural history or predict it. My question was on the survival curve that you put up with the HUR as the variable to look at. Was that all comers, both medically and managed or surgically managed, or was it one sort of population that was surgically managed and looking at HUR as a marker for survival?
Yeah, so that was all comers. That's kind of why I didn't necessarily spend as much time on that as the need for intervention, just because, of course, if you have an association with a need for intervention, that's going to impact your long-term survival. So it's all comers.
Nicely done, Zach. I think our current VSS president years ago, presented on sort of MGH's dissection, type B, large series, and found sort of risk factors for those that were going to plan to or wound up having intervention. Have you used these numbers and kind of compared to the classic things that we look at? Number of fenestrations, size of the intimal tear, total true plus false, and whether there's a reentry down in, looked like you had a lot that were re-entered down in zone 6 or 5, 6, 7.
Yeah, so, in terms of which of those classic predictors that we analyzed, we took a look at everything. We look at fenestrations as a predictor, whether there was 0, 1, 2, more than 2, et cetera. Looking at extent. I think we got into a little bit of small cell size problems with trying to do anything predictive, and all of this is univariate anyway, or univariable, I should say. So I think if we could do something more prospective, where we could try and have a little bit more rigor here, or just larger numbers, then I think that would get a ways towards answering that question.
Nicely presented, and thanks for bringing your talk to our meeting. So my question was, you found this odds ratio of 25, which is astonishingly high. Do you think we should be using these ratios as a decision maker as opposed to their symptom status, so as a means to doing prophylactic in these patients? And then my second question was, over that time period, has the protocolization for CT changed such that the timing of the bolus injection to the time of arterial phase scan and venous phase scan changed? And obviously that matters based on cardiac output, heart rate, et cetera. So curious if you looked at that at all or if that mattered. Absolutely.
Yes, so with the second question first, absolutely. So in the arterial HUR, we're just comparing false and true lumen at every zone. And so you're sort of canceling out any differences in timing because you're just comparing lumen to lumen. So cardiac output and contrast timing, contrast dose, et cetera. when we compared two different phases, venous to arterial, we normalized each to the root to try and get a sense of that as well. Now, if you could get really detailed and talk about how there's different compliance of the aorta, and that's going to deliver contrast differently, but we weren't able to do that level of granularity. And with respect to the first question, I should clarify, this odds ratio of 25 is large, but again, that's for 1 unit change in the ratio, so from 1 to 2, which is a huge change in the ratio. Really, we're probably thinking more about, changes of 1 to 1.1, 1 to 1.2, and then your odds ratio would come down to a more typical 2.5 number. And I think this would be a great thing to add into the armamentarium of how we evaluate these patients. I don't think it should replace symptom status. It should maybe supplement that, but again, only if we have some prospective data to back that up later.
Hi, Rima Curry. Have you looked, or do you think there's any value in looking at arterial HUR over time in patients that come in with uncomplicated dissection to see who would eventually have no false lumen remodeling and benefit from intervention?
Yes, and actually that was sort of the pie in the sky goal for this project initially, but honestly it's a very tedious process to measure these, and to do it for multiple scans over time is just going to take more time than I had as a resident, so it's definitely a future direction.
Thank you.
Thank you very much.